Greetings, everybody, on behalf of Bombay Orthopedic Society. Bombay Orthopedic Society is one of the oldest societies in India. It is 68 years old. WIROC is the annual conference of Bombay Orthopedic Society. This year, we have made the concept of WIROC Global, where we have invited societies all across the globe. And we are happy to say that more than 87 societies have joined in WIROC Global. So I, on behalf of WIROC Global, thank SBOT for participating in this event. And on behalf of my president, Dr. Sangeet Gawale, and Dr. Vishal Gundani, my co-organizing secretary, and the entire Bombay Orthopedic Society Executive Council, I welcome every member of SBOT to WIROC Global, and all the faculty here. We thank you for participating. With this, I hand it over to Dr. Vincenzo, who is the coordinator and convener today. Over to you, Dr. Vincenzo.
Thank you very much, Dr. Ashok. It's a pleasure to be here in this WIROC. I'm the current president of the Brazilian Orthopedic Trauma Association. We have about 25 to 30 years since we start this in Brazil, this Society of Trauma. It also all began with Professor José Soares Hungria Neto, about, as I mentioned, 30 years ago. And it's a pleasure to us to be here with you and to have the opportunity to be one of the 68 societies around the world that can join the WIROC in 2022. So our activity today is going to be held by all of the members, and we're going to split this into two upper and lower limb discussions. The lower limb, it's going to be moderated by our colleague, Mr. Robinson Esteves Pires, and the lower limb and the upper limb is going to be moderated by our colleague, Dr. Sergio Rovinski. So with no more delay, I'm going to pass the word to my colleague, Mr. Robinson Esteves Pires, so he can start our first discussion. Thank you very much again on behalf of the Brazilian Orthopedic Trauma Association. We are experiencing trouble with Robinson's computer. So maybe if you don't mind to not, lose time anymore, we can invert the sequence. So Sergio, if you don't mind, we can start with you, please.
Just a second. So are you seeing my screen now?
Yes,
perfectly.
Yes.
And are you listening to my voice now? Okay.
Loud and clear and clear,
Oh,
loud and clear.
Loud and clear. Okay. So hello, everybody. I am Dr. Sergio Rovinski from SHOULDERPLANET here from São Paulo, Brazil. And I just want to thank Brazilian Orthopedic Trauma Society for being here with us. As we all know, I am a shoulder and elbow surgeon for 18 years now who does a lot of shoulder and elbow trauma. So I'm going to show one of the most difficult, interesting, and lovely cases of my life. And let's start with this. So this was one of the most interesting cases I have ever had. So this case was about a 38-year-old lady who lived in the Amazon. I use it to operate in the Amazon strongly, as my Indian friends know, from 2011 to 2019. And this is an Amazonic lady who had a proximal humerus fracture in the right shoulder in January 2018. She lives not in a big city. She lives in a faraway city, but is a very, very oriented lady. A phyllos plate was done by a local trauma surgeon, and the surgeon said to the family that the surgery was fine and everything would evolve nicely. Nevertheless, the patient evolved with strong pain since the very beginning of the post-operative scenario. The shoulder developed very fastly stiffness post-operatively, and such problems were never getting better after surgery, month after month. As per the patient and as per the family, the surgeon was always saying that everything was fine. And this lady, she was 115 kilometers away from the capital of the state on the southwest of the Amazon. So finally, she went for a second opinion with the local orthopedic surgeon, and the local shoulder surgeon saw the case. He could understand what was going on, and he gave me a call here 2,000 kilometers away from him, saying that Houston, we have a big problem ahead. So that was the AP X-ray of the patient about 11 months post-operatively. That was November 2018, 11 months post-op. I'm going to comment the AP X-rays, the AP view in a minute, and that was, and here we can see, for us who have a good experience in the area, that was a posterior dislocation, anterior or posterior, but I'm going to show you the CT in a minute, and that was indeed a posterior dislocation. I'm coming to the X-ray in a minute. That was a well-positioned left view, but it's not so conclusive as we all know. If we take a better look on the AP view of the shoulder, this is in green, the glenoid, and this is here, the proximal humerus. So it's obvious that that was a locked anterior or posterior dislocation, but you are going to see the CT in a minute, and CT was obviously mandatory. I would like to highlight that this lady lived 150 kilometers inside the rural Amazonic area, in a way that we don't have all of the nice exams that we would have. So she did a CT in old fashion, in which we only had the axial cuts, okay? But this is the CT in the axial view, in which we are seeing this 11 months or 10 months post-op. So what are we seeing here in this CT? The humeral head was posteriorly dislocated, and some screws of the phyllos plate, they were destroying the glenoid. We all have experience. I have a lot of experience in this field, so we can easily say that those screws, they were scratching, I would say, the glenoid for a lot of time, because it takes a lot of time to have all of this indentation of the screw, causing all of this bony defect on the articular cartilage of the glenoid. And gentlemen, she's only 38 years old. This is another CT view, and we can see here no previous signs of drilling in the humeral head, okay? And if we see this other image a little bit higher, again, no signs of previous perforation on the humeral head. So we discussed this case a lot of time. It took us a lot of time to figure out what we would do. But the thing is, to the best of our understanding, I feel very tranquil to say that much probably that was, in the beginning, a three-part posterior fracture dislocation, or maybe a two-part, but I'm pretty sure a three-part posterior fracture dislocation. And to the best of my understanding, the colleague would not have noted that the humeral head was posterior dislocated, and hence he fixed the humeral head on the glenoid. And this is why she was having a lot of pain since the beginning. And in my opinion, considering that there were no signs of perforation in the humeral head, I can assume that the real diagnosis was not fully understood by the local orthopedic surgeon. And now I have a patient basically 10 months after surgery, 38 years old, with this scenario, a clear destruction of the glenoid, which was being scratched by some screws of the phyllos plate, a chronic dislocated humeral head, which was unquestionably going to AVN, much probably, as a shoulder and elbow surgeon, I can say a very, very suffered rotator cuff. She was in agony. To be very honest with you, her life was going bad. The marriage was going bad. She was fired from her job. She was in agony, and that was the bomb we had to fix. So before I show you, my friends, what we did, Dr. Vincenzo, I would like to hear you with this very, very easy case, my good friend.
Thanks, Sergio. I think you did the summary very nicely. The fracture was never reduced nor fixed adequately.
Yes.
I think maybe this was a two-part, because I don't see any signs of bone healing, both in the lesser and in the greater tuberosity. So I think this was a two-part posterior dislocated humeral head. That was never reduced nor fixed, as I mentioned, you mentioned also. There is an injury on the articular surface of the glenoid, but again, the patient is very young.
Very young.
There are no signs of a vascular necrosis of the humeral head. And in my opinion, if you allow me to move a little bit further, I think with this age, with a humerus head that demonstrates no signs of vascular necrosis, I think we have to try to do an osteotomy and redo, or at least try to do a very nice osteosynthesis. I think this is the only way to try to salvage this humerus head, but the patient has to be completely aware that with this procedure, first, this humerus head can now have an avascular necrosis. Even though the humerus head has no signs of avascular necrosis, and there is a secondary bone healing after this secondary procedure, she can experience pain because she has a very large damage of the glenoid surface, and we don't know for sure the profile of the rotator cuff.
Yes.
And after all, she can have third surgery because she can have the fracture healed with no signs of avascular necrosis, but she can experience pain, and she will need a third surgery. But I will try to do an osteotomy and a fracture reduction and another fixation.
Even with the quality of the glenoid, Dr. Vincenzo?
Yes, because of the age of the patient. I think we have to try to salvage this humeral head, but we have to put the patient completely aware that she can have a bad outcome. Yeah, she can, despite of an adequate reduction, if the fracture heals adequately, if the humeral head still shows signs of no signs of avascular necrosis, she can keep on experiencing a dysfunctional pain, and because of that, she can need a third procedure, maybe in this third procedure to do a replacement. But I will try in this secondary procedure to salvage the humeral head.
Okay, and if you operated this lady in an ideal scenario, would you have in the operation theater a prosthesis ready to be used or not? This is a lovely question.
In the secondary procedure, or if I was treating the patient since the beginning?
See, if she came to you and you said, okay, I'm gonna try to do a reconstruction, would you have, by safety, some kind of prosthesis in DOT to use as a plan B?
Yes, for sure, for sure. I think it's necessary to have a prosthesis in the operating theater, because you can be the best surgeon, you know, but anyway, you cannot be successful in reducing and fixing this fracture. So I think it's necessary to alert the patient that maybe she can go for an open reduction and internal fixation, and at the end she can have a replacement.
Lovely. I would like to listen, Dr. Gustavo, Robinho, Dr. Luis Henrique. Do you want to say something about this case? I think that it's a very challenging scenario. I would like to listen to you boys before I show what I did. Robinho?
Sergio, it's a challenging case. It's a malunion in a patient with 38 years old, but I always try to do a reconstructive procedure. I think it's helpful in this case to use a 3D printing for preoperative planning to help the procedure, but I always try to do a reconstruction.
I fully agree, but this lady is living 150 kilometers away from the only big city of the state, and I use it to operate there for 8 years.
So I try to do an osteotomy, an intra-articular osteotomy, and fixation with a plate, screws in the right positioning.
Okay, and do you consider that intraoperatively that would be impossible?
Probably. It can happen. It can happen. But I think we have to try to do a reconstructive procedure.
Okay.
It's possible, but you have to have two possibilities: the replacement and the osteotomy. I try to do the osteotomy first.
Okay, and if you had a replacement in DOT, what kind of replacement would you think about? As a shoulder surgeon, I tell you, a Hemi, a TSA, a total shoulder arthroplasty, or a reverse. But we have to take into consideration that the glenoid much possibly would be destroyed. And we have to think about the status of the rotator cuff. Having said that, what kind of replacement would you have in DOT, Dr. Robinson?
Probably a reverse shoulder arthroplasty. Actually, I don't do this procedure, but I have my friends who do it so much better than me. I have my colleagues of the shoulder team, and probably the choice for this patient would be the reverse shoulder.
Good, lovely. Vincenzo, well, the other two panelists, they can speak if they feel comfortable too or not, but do you want to say anything else before I show you what I did and my rationale?
Sergio, if you don't mind, it's important for a few comments. I think the patient is about 130 kilometers from the capital, right?
Yes, yes.
But the patient got a very nice plate. It's not usually to have this kind of plate, and very cities around the big capitals. So there's a big problem because they got a colleague done a surgery with a very nice plate, but didn't get to the reduction.
Yes.
So for this kind of place, this kind of patient, it's very important to reinforce that you have to be sure that there's correct reduction of the dislocation for the head is inside the glenoid, and it's about to get reduction for the fracture outside. So I think we'll try, like Vincenzo and Robson, as commented, we try to reduce and fix again. We try it's very important for about the age of the patient. And even with the glenoid with some problems, but we try to refix the fracture.
Okay, good. Dr. Vincenzo, I am controlling the time. Do you want me to show what I did?
For sure, but if you allow me, just one comment more.
Sure.
I agree with what Luis just mentioned, that although we are talking about a patient that lives 100 or 200 kilometers far away from the capital of the state of Amazonas,
okay.
She had a very nice and fancy plate to
Okay.
treat her fracture,
Sure.
or at least to mistreat her fracture, but she had it. And
Yes,
again, we are
yes,
discussing
yes,
about
yes.
yeah, and again we are discussing about fixing and or redoing the fixation with an osteotomy, or to replace it. And if we are talking about replacement, we are discussing about a reverse total shoulder arthroplasty. So although we are 20 kilometers far away from the capital,
Okay.
we still have some resources. We still, I can understand that we still have some resources. If we have some resources.
Yes. No, I just want to tell you that she has insurance. She had insurance, and she would have access to a reverse with the insurance, but definitely that would not be people with such capacities to do that in the small city. So this is why she came to the capital.
No, I understood that. But what I mean is that if she has some resources and very nice facilities to have to get some exams, some preoperative exams, I think if we are thinking about to do a reversal, and we are thinking about maybe that there is an option to, instead of doing the reverse, we can do a total shoulder, a conventional one.
But
we have to we have to stratify the condition of the rotator cuff. So again, if she has very nice resources and nice facilities, she is a candidate as one of the preoperative exams to get an MRI, because with the MRI, despite the implant and the artifacts, we can study very nicely the function and the fat infiltration of the rotator cuff, and we can classify according to Goutalier. And also we can measure the volume of the deltoid muscle, because so far in the literature, this has been shown a good factor in terms of prognosis, even though we are thinking about to do a reverse. So before the surgery, the definitive surgery, I would go for an MRI study, mainly for these two aspects, to study the viability and the quality of the rotator cuff, and also to measure the volume of the deltoid muscle. If we have Goutalier less than 2, and we have nice deltoid, I would say that maybe she can have a total conventional proximal humerus replacement. If she has a Goutalier greater than 2 and a very nice volume of the deltoid muscle, I would go for a reverse.
Yes. So my comments are, we didn't do an MRI because we would be absolutely sure of the artifacts that we would have because of the plate. And we asked for an ultrasound that was not very conclusive. But as a shoulder and elbow surgeon, well, what was my rationale? The thing is, the status of the cuff would be quite bad, and I was absolutely sure. I didn't do any pictures intraoperatively because I went to a city in which I had never been, that was not my crew, and it was a very, very tense surgery. And this procedure took 5 hours in my hands. So we knew that the status of the humeral head would be quite bad, and I was absolutely sure that was the worst humeral head I have ever seen in 17 years doing this. The glenohumeral status of the cartilage was very, very bad, and we were ready. We had completely given up the idea of trying to do a reconstruction because we knew that it would be in a quite bad status. And I was ready for a TSA or a reverse. That was one of the most difficult surgeries in my life. I have a lot of experience with complex shoulder and elbow trauma as a shoulder and elbow surgeon, and it took me 5 hours to do that. So that was the incision that I have done. This is 1 week post-op. That is my incision, a classic extended delta pec. But take a look at the previous incision. That is a non-existing incision. So it just gives me fuel to conclude that the previous doctor didn't know exactly what he was doing. So the status of the rotator cuff was extremely bad. So intraoperatively, we decided to do a reverse. I did it. So these are the perforations of the screws on the shaft. This is 1 week post-op, the left view, and this is the axillary view. For pedagogical purposes, here I am showing you the clavicle. Here I am showing you the coracoid in green, and here I am showing you the acromion. And I knew that it would be challenging to do a reverse in a 38-year-old lady who was suffering incredibly. So this is 2 months post-op, absolutely lovely external rotation. The subscap was completely gone, but many papers are saying that the pec major can compensate internal rotation. I have other cases in my office with reverses in all the patients, of course, with similar scenarios. And she was having, of course, difficulty in the scapular plane elevation because of adherences in the anterior inferior capsule. So this is her now 4 months post-op. Very good external rotation, still some difficulty in internal rotation, and still it was not easy to do elevation. See the scapulothoracical compensation. But with good physical therapy, this is her 8 months post-op, and with an outstanding result. This is my best result in the 20-25 reverses I have done in the worst case. My best result in the worst case. Okay, lovely. And then the pandemic came, and the patient came after 1 year. This is the last time we saw her, September 2020. She was coming to the city again, 1 year, 8 months post-op. Everything was doing fine in the X-rays, the AP, the axillary view here. And this is the last time we saw her. She was using a mask because of the pandemic. I like to say everybody gained weight with the pandemic, but she lost weight. And this is absolutely fantastic. I would never expect such a wonderful result. This is my best result in a reverse in 17 years in the worst case. So she is absolutely aware of all of the problems we may have in the future. And I conclude telling you that I am already preparing an article which will be published in October in Argentinian Orthopedic Association magazine about the challenging of doing a reverse in patients below 40 because of this case. the guys of Argentina, they got crazy with this case and they asked me to write this article. And this is her elevation. So I conclude saying this. A reverse restores the center of rotation. It tensions the deltoid, which would be quite good in such a young lady. And it allows good ROM, as we have been improving the technique, and is a good solution for many cases without any panacea. Take home message number 2. It was the classical indication as a shoulder and elbow guy. I am is an irreparable tear in a pseudo-paralytical shoulder in a patient 70 plus. Okay, with few comorbidities, lucid, active, and collaborative. In 2008, we were discussing this, but the limits of science have evolved in the last 12 years. So the indications without any heroism and any panacea, they are increasing. Proximal humerus in fractures in elders, we know that's too much, but in very complex sequelae of the shoulder, it can be done regardless all of the problems in the future. This patient, she told us to conclude, Doc, if you are giving me, as you are telling, 10 to 12 years of a painless and good clinical scenario, and my life was being destroyed by that, I will thank you too much, and in 10, maybe 15 years, then we will see what happens. And I worry about that, but I am very proud of my surgery and my decision making. So I just want to say thank you to WIROC, to Bombay Orthopedic Society, to Dr. Vincenzo, and Brazilian Orthopedic Association. I invite you to see my YouTube channel with 55 videos, and it's a pleasure to see my project, Show the Planet, with such a beautiful crew. And Dr. Vincenzo, that's it, my friend.
Sergio, I have one question. Did you use graft bone, or did you think about it to use it? Because the glenoid had a bone loss.
But you mean if I did a reconstruction or even in the reverse?
In the reverse.
No.
Did you think about?
No, we thought about that, but the thing is that as I was expecting, the shaft would be in a good status and not the humeral head. So what we did is that the humeral head was in a very bad status, but we used it all of the not the cortical, the osso esponjoso, Vincenzo, the
medullary, the cancellous bone.
The cancellous bone to put in between the shaft and the graft. So I didn't prepare her, I would say her iliac crest, but I was pretty sure that the shaft would not be a problem. And one thing that I didn't mention is that, as a shoulder and elbow guy, the thing is, the version, Dr. Vincenzo, the version of the version of the glenoid in the axial cuts, it was maintained. So the status of the cartilage was catastrophical. But in spite of that, the version that was not a B2 or a B3 glenoid, it was I would say a type A. So having said that, I didn't have problems with glenoid itself. It was difficult to establish something that I can say, and you guys have a lot of experience, much more than me, is that, Vincenzo, I'm going to make a very nice statement. When you are doing a reverse in a degenerative scenario, the epiphyseal line is always there, but in a fracture, many times you lose the pattern. So to calculate the height of the stem is very difficult, but I knew that in this case it would not be, and it was not. But the thing is that Dr. Vincenzo, it was a beautiful result, And I was, I would say, bold, in my opinion, not irresponsible, but a lot of courage from my side to do a reverse in such a young lady. But I think it was a good solution. And it was the only case in my life in which I did it in a patient with less than 68. But having said that, I would like to hear you, Dr. Vincenzo.
No, I think you did great because, you know, we have to move forward and to break this paradigm that
Yes.
young patients cannot get a replacement. They
Yes.
can't get a replacement when we are not able to reconstruct, because they need to have a very good quality of life since the youngest ages.
Yes.
So we were educated as orthopedic trauma surgeons and orthopedic surgeons, as you are a shoulder and elbow surgeon, that only elderly patients
Yes.
can get some replacement. And this
Yes.
is not true, because we have to say to patients with 30, 40, and 50 years that they have to stay with the bad quality of life, having pain daily, because they are not very elderly to get a replacement. And this is not true. We have to give the quality of life that these patients are not having. So I think you did great. The only concern, Sergio, and this is, again, this is not against your surgery, because I'm totally okay with your surgery. I just mentioned that, but it's that we don't have so far very long follow-up studies with reversals.
Yes.
So we don't know in 15 years, maybe a little bit less than this, maybe a little bit more than this, but we don't know so far what will gonna happen with these reversals. So my main concern, yes, exactly. My main concern is about the bone stock in the glenoid, because as we know, the glenoid is a very small piece of bone with no much good bone stock.
Yes.
And maybe if we have some bone loss in the glenoid, we have nothing to replace this. But again, congratulations for the case. I think it was a very nice solution, and you gave to this lady the quality of life that she lost for 2 years.
So, to be very honest with you, just to finish, this is what makes me sleep with peace. I know that in 10 years, I may have a big problem. That was discussed with her, but I'm gonna tell you, she's so happy with the quality of life. And you said something so important. So she would have been pain with a reconstruction only because she was around 40, and now she's happy. She's so happy. So I think that it was it's a very difficult case, Dr. Vincenzo. It's a very complex case. But the thing is, this is a caricature, the only caricature I have in my life to discuss reverse in younger patients. But I think that in spite of all of the long-term problems, that was a good, not only a beautiful surgery, but I would say a reasonable decision-making process.
Totally agree. Totally agree. And as I just said, congratulations for the nice case. It was very nice. Not only, as you meant, not only the surgery, but the final result.
Yes.
And I think she got this very good result because she was all over the follow-up. She was regaining the volume of the deltoid muscle. And this is why sequentially you improved, or she improved, the quality of the elevation in all planes. Congratulations again. Thank you very much for the case.
Robinho.
Okay. Very nice case. Congratulations.
Lovely.
I'll share my screen. Let's move on with okay. Can you hear me?
Yes.
Okay. Oh, this is an interesting case. This is a patient, 50 years old. It's a male patient who suffered a fall of a horse and presented this kind of fracture, this fracture pattern in the tibial plateau. You can see here the 3D CT reconstruction, but this patient was initially treated in another hospital 3 hours from my city. And I don't have full information, lots of information about the case because he was referred to me further. But you can see here that this patient had an ACL reconstruction prior, and the information that I had that was that this patient presented lots of edema and soft tissues problems. And this patient was initially treated by a friend of mine, but I'd like to hear the opinions about my friends. Luis, how do you deal with this kind of fracture in the first care?
Okay, you have a big problem. We have some fragments, articular fragments that get the distal femur inside of the plateau fracture. So there's some impaction, very important impaction. So as you said, you have soft tissues problems. For the first step for this is put an X-fix, get some reduction, put in a correct position. And I would like to wait for the getting better conditions for the soft tissues, or you have some picture for that, or start doing some fixation.
Okay, let's move on. This patient was treated by a friend of mine. He tried to do the reduction and fixation of the fracture. The patient evolved with a compartment syndrome, and maybe it's some kind of infection. I'm not sure about this information, but this patient was referred to me after 7 months, presenting knee stiffness and a painful knee, like you can see here. And I asked my dear friend Vincenzo, now what, my friend? What to do? This is a 50-year-old male patient with this kind of fracture, a malunion, and he's a farmer, very active. And how do you deal with this kind of problem here?
Yes, thank you, Robinson. As you mentioned, this is a huge problem because we have a wide tibial plateau. You can see that there is an incongruency between the lateral femoral condyle and the lateral tibial plateau. Yeah. There is the plateau is wide. Also, there is an inclination of the old fragment that was split, and the depressed fragment is still depressed. I mean, there is no correction of this lateral condyle, lateral tibial condyle. So what I think we have to do now is to have a very nice imaging study, and I would add, in addition to this X-rays, I would add a CT scan, and with the CT scan you can suppress the distal femur, so you can have a look at the tibial plateau from an axial perspective without any artifact, without the femoral condyles. And with this, I think we have to redo this fixation, but with a very nice preoperative planning, with articular osteotomy. So you mentioned about the 3D printing in the proximal humerus that Sergio just presented to us. I think this is a very nice indication to have a 3D printing after the CT scanning, because you can truly understand what is happening, mainly in the central part of the lateral condyle, because you can't say by sure that how much this is depressed and in which part this is depressed. If this is anterior, if this is more central, or if this is posterior, because of the implants and because of the femur. So I would go for a CT scanning, and if I have condition to have, I would also order a 3D printing before my definitive surgery.
Robson, if you don't mind, the question for me is, that you said the patient had a compartmental syndrome. So there's any kind of some neurological problem with the patient?
No.
And also, as Vincenzo commented, there's an incongruent joint with the lateral part of the plateau, as well the medial part. So there's some kind of the instability with the ligament for the knee, exam.
No, no neurovascular injuries and no gross instability. But of course, it's a difficult clinical examination for this patient because he presented a knee stiffness and painful knee, and just the mobility was around 30 to 50 degrees. It's very hard to get a very good examination, clinical examination, to see about knee instability. But he had a reconstruction of the ACL several years before, like you can see here, and now you can see the CT scan. And now what? Gustavo, what's your opinion about that? What do you do in this situation? 50 years old.
It's a terrible result, and the patient is young. I think about it, we need to do something to reconstruct this articular surface, and the interarticular osteotomy is the better solution that I think. But Vincenzo told us very well. It's very difficult to plan the strategy only with 2D images. And the 3D printing is a good solution to do the surgery before the real surgery. If you have this possibility, I will do this.
Vincenzo, what do you prefer? To do an implant removal first in one time, and in the second time to do the osteotomy, or doing at the same time? What is your preference?
You know, this patient is very complicated. So I would go in the first step with the implant removal and the articular inspection with an arthroscopy. After that, I would repeat the CT scan with no implant to now understand what I have to do in terms of the bone reconstruction, because I just understood what is happening with the soft tissues inside the joint, because I did in this first step an arthroscopy as well as the implant removal. So after that, I can have the exactly scenario. So I truly understand what is happening in the articular joint. I mean, what is the status of the ACL reconstruction? What is the status of the meniscus? What is the status of the cartilage? And after that, I can have a very clear understanding of the bone and joint. So I would say that now I know everything that I need to promote an articular osteotomy. So I would do this in two steps.
Okay, we can see here that we have a widening of the tibial plateau, a posterolateral depression, actually, like you can see here. And this was my preoperative planning. I tried to do an intraarticular osteotomy And I usually have this clamp to perform the reduction of the knee, not the reduction of the fracture, because this is actually a fracture dislocation. And after that, perform the reduction of the tibial plateau and the fixation. But it's easy to do in the paper, but it's not easy to do in the real life. In the real life, no.
Yeah.
And this is the image of the arthroscopy, and we can see here the depression of the posterolateral tibial plateau, and we had to change plans during the intraoperative surgery procedure. And I tried to do a lateral window as well to perform the reduction of the posterolateral depression. And I additionally, I did an osteotomy of the lateral epicondyle of the femur to look over the tibial plateau inside the posterolateral tibial plateau to have an adequate reduction of the posterolateral surface. And here you can see the intraoperative fluoroscopy images. Here with the K-wire, the intra-articular osteotomy, and the fixation of the lateral epicondyle osteotomy, and the correction of the widening of the tibial plateau, the posterolateral depression as well. We didn't use a bone graft. And here you can see the result with the patient with the stitches. And you can see so much better range of motion with a full extension and maybe 120 degrees of range of motion or flexion of the knee. And I'd like to know the opinion of my dear friends. Gustavo, what do you think about the procedure?
You are magic.
Yeah.
Very, very nice result. Do you need to drop the stiffness during the surgery, or only with the osteotomy do you win this movement?
Robinson. No, just a second. I would ask the same thing of Dr. Gustavo. So I will just make the same question with one thing else, which is, how did you manage to get intraoperative movement during the procedure? Was it before the new osteosynthesis, or was that after the new osteosynthesis? Did you do a capsulotomy, yes or no? And if yes, when?
So it was a very challenging procedure. I was actually absolutely afraid about the vessels and the posterior surface of the knee. But I had a total view of the knee in this case, because I removed a wedge, intra-articular wedge, and I did a capsulotomy to see some adherencia. Sorry.
Some adherences.
Yes. So I was progressively gaining range of motion during the procedure, but after having a congruency of the joint, it was so much better, because it was like a magic, like you told. I didn't have to do a posterior release of the knee, nothing like that. Just gaining the congruency of the joint and correction and performing the correction of the widening of the tibial plateau and the posterolateral depression. It was reasonable, and it was not hard to get the range of motion. It was
Robinson, just one more stuff. I am not an inferior limb guy. I am an upper limb surgeon. But what about the ACL and the PCL? Were they integrated? Were they torn?
No, they were not torn. They was the surgery. The prior surgery was not damaged or injured.
Okay.
No.
Okay. Robinson, I have a question about the time of the surgery. You did this in one procedure or you did two procedures? You did, for example, you showed an image of the knee arthroscopy. Did you do a knee arthroscopy before, and then in a second time you came back with the patient to the OR and did the definitive surgery or not?
Just one surgery. Just one surgery. Arthroscopy, implant removal, and reconstruction. At the same procedure. And this is the patient with 2 months with a very reasonable result. And this is the patient with 8 months, some degree of claudication, but he is actually, at least until now, free of a replacement. I don't know when he's going to require a replacement, probably in the near future, but we are gaining some years to do it in a better situation, no? And this is the final result of the patient. We have 8 months of the surgery, and I'd like to know your final comments. Maybe Luis?
Robson, I think the key, the very important key for the procedure, your success of this case, was when you did realize the problem during the surgery. You realize that there is not correct reduction for the lateral part of the plateau. So you have to change your mind, your approach, do the offshot, the lateral epicondyle, and you see correct reduction for the posterior part. I think it was not so easy to get a reduction in the knee with just intra-articular osteotomy. I think the best way is to get some correct reduction, remove that bone impact posterior, so you can get better, get back for the plateau articular surface. So it's very nice. Congratulations for the case. It's very nice. And this is the key, because you have to understand the fracture to get the correction for the reduction of the articular part. It's very important. Very nice. Beautiful.
And if you allow me to add some of my findings about tibial plateau, I totally agree with what Luis just said. And one of the things that our audience have to think about when managing tibial plateaus is that the knee is very acceptable with certain degrees of step-offs and gaps. As soon as you have 3 mandatory things by the end of your procedure. The first one is to have the knee completely aligned into the normal valgus. Okay. This is one of the first steps. The second one is that knee has to be completely stable. If you have a very nice PCL, ACL, and the collateral ligaments, and of course the posterolateral corner, the knee is stable, and because of that, there is no instability that promotes more secondary articular or cartilage damage. And the third point, that this is the newest one, we get this from the very, very new literature, is that we have to have a complete congruency between the lateral part of the lateral femoral condyle and the lateral part of the lateral tibial plateau, as well as in the medial part. So there is no possibility to have a tibial plateau wider than the distal part of the femur, because if we have that, we can expect for at least some complaints related to meniscus injury. So if you have these three points by the end, you can expect a very lifelong knee during, you know, patients' functions, sports, and so on. And probably, despite by the years, Robinson, you're gonna experience to see some degree of degenerative osteoarthritis. Probably these patients will never get a knee replacement. This is what I think about tibial plateau.
Okay.
Okay, Vincenzo, thank you very much. I recommend you to read a paper that was published some years ago by Professor Mauricio Kifuri and Professor Schatzker about intra-articular osteotomies around the knee.
Okay.
I have here probably, yes, this is the paper. It's a very, very interesting paper about cases like that, when you have to think out of the box and try to do a solution and maybe avoid some replacement in a relatively young patient. So thank you very much.
Thank you, Robinson. Very nice case, as well as Sergio show us. Mr. Ashok, I think we did it. Again, on behalf of the Brazilian Orthopedic Trauma Association, I would like to thank you very much for the invitation. As well, I'd like to thank my dear friend Sergio Rurinski, because he intermediates all this stuff. He's a very kind guy. We like him a lot, although he's not a trauma guy. This is a pity. But again, thank you, Mr. Ashok, very much for the time that we just had in this meeting from the WIROC. And I hope we can be together again, probably face to face, better than behind the screen. But I hope we could have at least this 1 hour of a scientific discussion. And for the audience, I hope this was very nice. Thank you, Mr. Ashok.
Thank you very much, Dr. Vincenzo, and it was an excellent session, excellent case discussion by all faculty. And I, on behalf of WIROC Global and Bombay Orthopedic Society, we thank the Brazilian Society for Orthopedics and Traumatology. Thank you very much. Thanks all faculty, and we'll invite all your members to WIROC Global. We'll send you the link very shortly. Thank you very much.
Thank you. Thank you, everybody. Thank you, Vincenzo, Robinho, everybody, Guga. It was a pleasure to have you here. And in the name of the Bombay Orthopedic Society, which is gigantic in India, I also thank you very much. Okay.